So it is 8:35. I think we can start. Lingraj, should we start? I think because otherwise it will take more time.
Yeah, sir, we can start now.
So, Shravan, so start presenting your case.
Yes, sir. Sir, am I audible, sir?
Yes, you are.
The screen is visible, sir.
Yeah.
Good morning, all. So today I'm going to present a case of 27-year-old lady who is a Hindu, unmarried, engineering student who is from resident of Jalgaon, Maharashtra. She presented to our OPD with the chief complaints of swelling in the left side of the neck since 2 months, with swelling in the right side of the neck since past 1 month, and history of presenting illness. Patient was apparently all right 2 months ago when she noticed a swelling in her left side of the neck, which was gradually in onset and progressively increasing in size over past 2 months. When she noted the swelling, initially it was a small peanut-sized swelling, and since past 1 month, she also noticed a swelling in her right side of the neck, and which was initially very small in size. And over the past 1 month, the size of the swelling is started increasing. Apart from the swelling, both sides of the neck, she doesn't have any history of pain in the swelling, no history of any redness or discharge from the swelling she noticed, and there is no history of any other swelling in other parts of the body, and she does not have any history of fever, no history of any anorexia, weight loss, or night sweats. There is no history suggestive of any itching or skin marks, and there is no history suggestive of any high-risk sexual behavior, and there is no history of cough or dyspnea or no abdominal symptoms. So past history wise, she doesn't have any significant medical comorbidities. She does not have any history of tuberculosis. Recently, 4 days ago, on OPD basis, she underwent a minor surgical procedure from her right side of the neck where needle got inserted and sample sent for further analysis. And there is no history of any blood transfusion. Personal history, there is no history of any addictions. Bowel bladder habits were normal, and her sleep and appetite were normal. Family history, there is no history suggestive of familial history of malignancies, no history of any tuberculosis in family members. Menstrual history, she's a premenopausal lady with the last LMP on 21st of January, and her cycles were regular, 4 to 5 days, normal flow, no menorrhagia. So to summarize, 27-year-old lady who presented with bilateral neck swelling since past 2 months with she started noticing size of the swelling increasing over the past 2 months with no history of any B symptoms and no history of swelling in any other sides of the body.
So, Shravan, at the end of your history, what are the differential diagnoses that are there in your mind, and what are the reasons for those differentials?
Yes, sir. So at the end of the history, my differentials will be as follows. So the first differential in her will be lymphoma, probably Hodgkin's lymphoma, and the second possibility is non-Hodgkin's lymphoma, most probably high-grade lymphoma like DLBCL. And
okay, so you are putting lymphoma as your first differential, followed by tuberculosis.
yes.
And what is the reason for that?
So in a young 27-year-old lady with rapidly worsening lymphadenopathy, so the first probable diagnosis, first differential could be the lymphoma, sir. And at this juncture, I can't really differentiate between malignant versus benign condition. So there could be a possibility of infectious etiology, tuberculosis also.
Yeah, so tuberculosis is also very common in our country, and many young people can develop tuberculosis.
Yes.
So it is not that lymphoma is more common. Tuberculosis definitely is more common in our country. So as far as just the incidence goes, tuberculosis is more likely. But thing that is going against tuberculosis here is there is no fever, there is no weight loss, there is no history of tuberculosis in the past. Is there a family history of tuberculosis? You didn't mention that. Anybody in the family
no
with active?
family history of tuberculosis, sir, actually.
Okay,
And
so
no,
somebody who's got open cocks in the family makes that more likely.
yes,
But
sir.
in absence of these, tuberculosis can present with just lymphadenopathy without fever also. It's not that it can't occur, but both of these will be the differentials. Okay, and probably lymphoma more because there's no fever, there's no anorexia.
Yes, sir.
But tuberculosis is also certainly a possibility. So these two differentials, I would agree. Are there any other infections that can present with lymphadenopathy?
Sir,
Neck nodes.
one possibility could be with neck nodes history. Retroviral illness can be one other
So it
differential.
is less common that retroviral lymph node will come just with neck nodes. They will usually have generalized lymphadenopathy. Presenting just like neck nodes is less common. Infectious mononucleosis can present with neck node, but all of them will have fever. All of them will have, most of them will have splenomegaly, and the symptoms won't last for 2 months. So I would agree with these two differentials. I don't think any other differential needs to be kept in this case. All right.
Yes,
So
sir.
why did you ask for fever and you said there are no B symptoms? So what are the B symptoms that you're looking for, and why do you look for these B symptoms in lymphoma?
Sir, the B symptoms, which includes fever more than 38.5 degrees Celsius and unintentional weight loss of more than 10% over past 6 months with history of anorexia and drenching night sweats. So these are the B symptoms usually will
Okay.
happen.
What should be the weight loss? How much should be the weight loss to
More
call
than
it to be
10% from the
more
base
than 10% in 6 months?
6 months, sir. Yes, sir.
Right. So if that is present, then why is it significant to ask this history in lymphoma?
So the presence of B symptoms helps in management of the patient in terms of treatment and prognostication, sir.
The most important is prognosis. Presence of B symptoms tells that there is more tumor burden and more aggressive disease, and these patients do less well compared to those patients without B symptoms. All right.
Yes,
So that is the reason why you should ask for B symptoms.
yes, sir.
So now with in this differential, you say that you've got NHL, DLBCL, and Hodgkin's. Is
Yes,
it
sir.
possible based on history to differentiate whether what kind of lymphoma it is, non-Hodgkin's lymphoma or Hodgkin's lymphoma?
Yes, sir. So one clue in history is like, sir, there is a lymphadenopathy which is bilateral cervical. So it is a contiguous lymphadenopathy without any lymph nodes in other sides of the body. So the contiguous lymph nodal involvement most common in Hodgkin's when compared to the non-Hodgkin's lymphoma.
Yes, very good. So the contiguity and the spread of lymph nodes can help you get a differential diagnosis. Anything else in history that can give a clue? Anybody else wants to answer this question? Any third years? Anything else present in history? If you know that this is a probable lymphoma, anything present in history can give you a clue whether this is a Hodgkin's versus a non-Hodgkin's lymphoma. Any third years can answer. Nobody? Alok?
The rapid onset of symptoms within 2 months is more in favor of high-grade lymphoma.
Agreed. Agreed. So this has been there for a short duration. Within 2 months, it has spread from one side to the other side. So this goes more in favor of a high-grade non-Hodgkin's lymphoma. For Hodgkin's, this would be a bit too rapid, although it is possible. We can't completely rule out, but the rate of spread goes more in favor of a non-Hodgkin's lymphoma, because within 2 months, this has not only occurred, but it has spread to the other side also. Okay. One thing is that presence of symptoms, systemic symptoms like generalized pruritus, as well as increased pain after alcohol consumption. These systemic symptoms more point towards a Hodgkin's lymphoma rather than non-Hodgkin's lymphoma. But these are not that commonly present. These are very rare. But if present, they would, would tend to be more present in Hodgkin's lymphoma. And more importantly, it is important to document these symptoms because many of the times when these patients relapse, they tend to have this pruritus symptoms coming first before they relapse. So it can be a kind of a marker for relapse also. So these are two questions that you can ask to the patient to kind of get a clue whether it is Hodgkin's or non-Hodgkin's. Nevertheless, you can never be sure without a biopsy. You always need an examination and a biopsy to confirm the diagnosis. So I would agree with these two differentiations, Shravan, that lymphoma is probably the first possibility, and I would place NHL over Hodgkin's lymphoma because of the rapidity of the onset, and tuberculosis may be a second differential because in our country it is very common and you cannot completely rule it out in the absence, even in the absence of systemic symptoms.
Yes.
All right.
Yes, sir.
So we will go to the examination now.
Yes, sir. General physical examination. Patient was examined in broad daylight in presence of female attendant with the verbal consent. At the time of examination, patient was moderately built and nourished. Her height was 163 centimeters, weight was 50 kilos, and BMI of 18.82, which is normal in limit, and BSA of 1.50. She's ECOG performance status 0, and she was hemodynamically stable with the pulse rate of 89, and she is afebrile with a temperature of 98, blood pressure of 110/70 millimeters of mercury. Respiratory rate was 18 breaths per minute. Saturation was 100%. No pallor, no icterus, no clubbing or cyanosis, no edema. So there is a scar present on right side of her neck. Coming to the lymph nodal examination, she had bilateral cervical lymphadenopathy, regions of level 1B and level 2, and the largest lymph node was in of 4 to 5 centimeters in right level 2, which was discrete, round, non-tender, foam in consistency, and not fixed to the overlying skin or underlying structures with no local rise of temperature. And there is a mild bilateral tonsillar enlargement was present. Systemic examination was unremarkable. No skin lesions, skull and spine were normal.
So any other physical findings you could elicit on general examination?
No skin scratch marks, nothing.
Okay. So go one slide back. So you have said there is a level 1B and 2 lymph node.
Yes.
Okay, so what do you mean by, can you describe the levels? Where is level 1? Where is level 2? Where is level 3? Where is level 4? Where is level 5? Where is level 6?
Yes. So level 1 is submental, sir. Level 1A, level 1B is submandibular. Level 2 is cervical upper jugular. Level 3 is middle jugular. Level 4 is lower jugular. Level 5 is supraclavicular. And level 6 is infraclavicular.
So level 5 is actually posterior triangle,
yes,
that is behind the sternocleidomastoid.
Yes.
Okay, and level 6 is pre-thyroid, present anteriorly in front of the trachea. Okay, so this is basics and you should know. So you have rightly described that whether it is discrete. What do you mean by discrete lymph node?
So it is not, there is a clear demarcation between the lymph nodes, sir.
Okay, as opposed to a matted lymph node.
Matted
what is a
lymph
matted lymph node? When will you say it is matted?
So the two adjacent lymph nodes, we can't differentiate.
So when the lymph node present as an en masse lymphadenopathy and you cannot kind of move the lymph node separately. When you move one lymph node, the other lymph node also move together with it. It is like a network of lymph nodes. Then it is known as a matted lymph node. Right. And you have also said that it is not fixed to overlying structures. So what is the importance of this? What will something that is fixed to the you mean overlying structure or underlying structure here?
Sir, underlying. Sorry.
Yes, you have written overlying skin or underlying structure. Yeah, correct. Overlying skin or under. What do you mean by what is the significance when a lymph node is fixed to underlying structure?
If the lymph node is fixed, it suggests of infiltration of the subcutaneous
Yes, infiltration of the subcutaneous is
tissue
and the underlying fascia and the muscles. Okay,
yeah.
and what will it help you in your differentials if something is fixed lymph node? A metastatic lymph node is many of the times fixed,
Yes.
whereas lymphoma is usually not fixed and it is discrete. Okay, so a metastatic lymph node will uh, uh, is usually a presence of a fixed lymph node tends to point towards a metastatic disease rather than a lymphoma.
Yes.
All right, so that is the importance of this.
Yes.
Okay, and go to your next slide.
Yes.
So whenever there is a case of cervical lymphadenopathy, you should always do an oral cavity examination. Okay, and if possible, you should do a Hopkins examination, especially if it's an elderly patient or patient who's got a history of tobacco chewing or smoking. Okay, because many of the time, primary from the oral cavity or from the oropharynx or from the vallecula or the larynx can present with cervical lymphadenopathy. A laryngeal primary obviously will have some symptoms related to the voice, but many of the times from other sides there may not be any symptoms. So it is important to do a oral cavity examination. In your examination, you had no finding apart from bilateral tonsillar enlargement.
Yes.
Okay, so is there any significance of this finding of tonsillar enlargement?
Sir, if it is a if it is a painless tonsillar enlargement, then it could be a tonsillar DLB cell with cervical lymphadenopathy. Tonsillar NHL.
So tonsillar involvement is very less common in Hodgkin's lymphoma. It usually happens in non-Hodgkin's lymphoma. Here you have said mild bilateral tonsillar. If it's a mild hypertrophic tonsils, we don't know. It may be physiological also. But if there is a unilateral enlarged or a significantly enlarged tonsil, it usually points towards a non-Hodgkin's lymphoma rather than a Hodgkin's lymphoma. So that is an important finding in your examination. All right. Okay. Go to your next slide.
Yes.
So is this all in your examination? Do you want to examine something else also? So
She is a female.
what are the organs that you should see in when you have a lymphadenopathy? Is it just the lymph node or a lymphoreticular examination? What are the organs that are present in lymphoreticular system?
So apart from the lymph nodes in lymphoreticular system, we will have the liver and spleen, sir.
So have you mentioned that?
Yes, sir. All systemic examination was unremarkable, sir, except the lymphadenopathy. So
Okay.
I mentioned like in entire.
Okay, that's fine. So, but no, if there is, if it's a case of lymph node, you have to specifically mention. Just don't write unremarkable. You have to write that you have examined the abdomen and there's no hepatomegaly or splenomegaly, because that will completely change the picture.
Yes.
In this case, all right. So make sure that you just don't make it a passing remark and you stress that you have examined and
Yes.
there's no hepatosplenomegaly when there is a case of lymphadenopathy.
Yes.
All right.
Yes.
So that's fine. So at the end of your physical history and physical examination, what are your differential diagnoses?
So except the lymphadenopathy, which is substantiating from the history and supporting, otherwise no other findings have on examination. Still, my differential at the end of history and examination, still I'll go with the lymphomas.
Yeah, I would also agree that lymphoma would be the first differential here. So what is your next step in this patient?
So I would like to prove the diagnosis of this patient with further evaluation, sir.
All right.
So diagnosis for this patient will be the excision of the lymph nodal mass for the biopsy.
Okay. So, and whenever you ask for investigation, you have to say basic investigation for evaluating the general fitness, and for diagnosis and staging of your lymphoma. So what are the basic investigations that you will do for this patient?
So after confirming the diagnosis, basic investigations, I will do complete hemogram with peripheral smear to look for differential counts and to look for any atypical lymphocytes. And
Okay.
after the
So
CTC and LDC,
what is the probability that you will get atypical lymphocyte on the peripheral smear? So if this is a lymphoma, this is likely an early stage lymphoma
yes,
because there's only neck node involvement and there's a 2-month history.
yes,
So peripheral smear may not help you um, uh, re- uh, in this case. If it's an elderly patient in whom you are suspecting a low-grade lymphoma or there is generalized lymphadenopathy, yes, then peripheral smear will help you clinch a diagnosis. But in this case, peripheral smear will really not help you much. Okay,
yes.
but CBC you must do. Anything else that you want to do?
So CBC and differential count and baseline organ function test I will do, sir.
Okay,
Look for the fitness, which includes renal function test and liver function test. And as it is a lymphoma, so to rule out any tumor lysis syndrome, baseline electrolytes, sodium, potassium, phosphorus, calcium, and I'll look in.
what
And
about LDH? Do you want to do
LDH also
LDH?
to, sorry, LDH also I will do.
So why is LDH important? What does it tell you?
So the importance of LDH in lymphoma is the tumor cell burden, sir, tumor turnover. If it is a high LDH, then we can say that the tumor is rapidly proliferating and high tumor burden.
Okay, and it is prognostic also,
Yes,
right?
prognostic.
Okay, and for getting a diagnosis, what investigation has she been investigated? Any test has been done for her?
So this is the one FNAC she underwent on 24th of January, sir, at outside center. So there is a FNAC from the bilateral submandibular lymph node, which is suggestive of high-grade malignancy. So they have mentioned it as a high-grade NHL, probably DLBCL, like DLBCL.
Okay, so which lymphomas can you diagnose on FNAC? Can you diagnose any lymphoma on FNAC?
Lymphoma on FNAC.
So FNAC is not useful in diagnosing lymphoma, and for lymphoma you need a biopsy. So you never start treatment of a lymphoma based on an FNAC report. You have to confirm it with a biopsy, and what ideally an excision biopsy wherever possible,
Yes.
right? So in ideal situation you should get a excision biopsy of a whole node because that is what will give you the complete architecture of the lymph node and help you get the diagnosis of lymphoma, right? If it's a not neck node, you should get an excision biopsy. If the lymph node is present in the mediastinum or the abdomen where an excision biopsy may not be possible, then you should try and get multiple cores by a guided biopsy, right?
Yes.
So FNAC may not be the correct investigation in this case, and biopsy is uh, the one that will help you get a diagnosis. The only reason to get an FNAC is when it's an elderly patient and you are suspecting a carcinoma. That time, doing an FNAC can give you a rapid diagnosis of a carcinoma. But for a lymphoma, FNAC is not of much use, right? So, have we done a biopsy in this case?
So yesterday only she was presented, so far no biopsy.
Okay, so we don't have a biopsy. Okay, so we would want a biopsy. Is there any staging investigation we would like to do?
So to do the baseline staging, I will do the PET CT, sir.
Okay. And why you want to do a PET CT, not a plain CT?
So PET CT to look for the systemic involvement, liver, spleen, and as well as other lymph nodal stations.
So is a PET CT better than a CT?
Yes, lymphoma
Yes,
is
so it is.
FDG.
Why is it better?
So if you are dealing a high-grade lymphoma, the FDG avidity will be more in high-grade lymphoma. So the investigation of choice, whenever available, it is PET CT over the CTs.
So PET CT can help you better stage a lymphoma compared to a CT. PET CT would upstage stage, at least 10 to 20% of the non-Hodgkin's lymphomas compared to a CT scan, and especially extranodal involvement can be picked up better with a PET CT. So now PET CT is the standard staging modality for non-Hodgkin's lymphoma, and you should get a PET wherever possible. Only in cases where you actually don't have access to PET CT, you can go ahead with a CT. But now even in a smaller cities, PET CT is available. You should try and get a PET for diagnosis and for accurate staging of the lymphoma. All right.
Yes.
So has a PET been done for her?
So PET is yet to be done. That is also planned next Monday.
Okay, and so you don't know the diagnosis as of now.
Yes.
So which are the lymphomas in which you would order a PET, and which are the lymphomas in which you won't order a PET?
So the PET has a high FDG avidity in high-grade lymphomas like DLBCL, Burkitt's
Okay.
lymphoma, and
Okay.
other immunoblastic lymphomas like anaplastic large cell lymphoma.
Okay. What about Hodgkin's lymphoma?
Yes, sir. In Hodgkin's lymphoma also there is a high FDG avidity of 96%, 96 to 98. So we can.
What about follicular lymphoma?
So follicular and marginal zone lymphoma, like splenic marginal zone lymphoma, the FDG avidity is less, but still we can.
So follicular lymphoma also, most of the patients will have FDG avidity, and follicular lymphoma also you can order a PET upfront. Okay. For marginal zone lymphoma, small lymphocytic lymphomas and CLLs, chronic lymphocytic leukemia, PET avidity is not there, and you can order a contrast enhanced CT for staging. Okay. But for follicular, Hodgkin's lymphoma, DLBCLs, Burkitt's, PET CT is the standard staging modality.
Yes.
Okay. So this is important to know, right? So now that you have got a PET CT, suppose PET CT shows that there is only bilateral cervical lymphadenopathy, and the lymph node biopsy is a diffuse large B-cell lymphoma. Okay, how will you, what will you counsel this patient, and how will you treat this patient?
So if it is a stage, so if for only DLBCL with only bilateral cervical lymphadenopathy with this history and examination, so she will come into the stage 1A, sir. So and with the IPS score of 0, so the standard modality of treatment in her stage 1A DLBCL is like I will counsel in lines of chemotherapy along with chemoimmunotherapy like R-CHOP regimen. 3 cycles I will counsel.
Okay, so she's a 27-year-old girl. So she asks you, doctor, that now I've got cancer. What is the chances that I will survive? So long term, how long do I have to live? What will be your answer to that question?
So with this chemoimmunotherapy in current standard rituximab era, with NCC with IPF 0, the 5-year survival rate is of almost 87 to 90%.
Okay, so if you are giving immunotherapy, would you want to do an IPI score or an RIPI score?
RIPI.
What are the components of RIPI score?
Age, performance status, LDH, extranodal sites, and stage.
Okay, and what is the prognosis based on RIPI? If the RIPI is 2, what is the survival? If the RIPI is 5, what is the survival? Expected survival?
So RIPI 2 survival is 67%.
So how many categories are there of survival based on RIPI? So there are 3 categories: very good, good, and poor. So those who have an RIPI of 0, the score is almost 90% 5-year survival.
Yes.
RIPI of 1 or 2 has a survival of 80 to 85%, whereas those who have RIPI of 3, 4, 5 have a poorer survival around 50 to 60%. So you get 3 three groups in this RIPI, and that's why it helps in survival. So if it's an 18-year-old girl, is there any other scoring that you can use? Other scorings that you know of?
Apart from IPA, RIPA, 18.
Have you heard of age-adjusted
age-adjusted
IPA?
Yes,
So that is used for patients less than 60 years. And what about NCC and IPI? So that is also NCSI and IPI is also another scoring that based on age there is risk stratification, right? So you should be aware of these three scorings. Okay, and in when you are using rituximab, you should use the RIPI score and not the IPI score. Although it is the same, the survival implications are a bit different.
Yes.
Okay. So how will you treat this patient?
So she is stage 1A DLBCL. So the standard of care in her case will be 3 cycles of RCHOP with IF40 cell.
No. First, so you want to give RCHOP.
Yes, sir.
Rather than CHOP. So why do you want to give RCHOP? What is the data that RCHOP is better than CHOP?
So,
you are right, but I am asking you, what is
yeah.
the data that RCHOP is better than CHOP, and what is the survival advantage with RCHOP compared to CHOP?
So head-to-head the comparison of CHOP versus RCHOP came from MINT trial, sir. So,
Yes.
so MINT trial addition of the rituximab to the CHOP standard chemotherapy based backbone. So it has improved survival rates and response rates.
Okay. By how much has the survival improved?
Like figures, I'm not aware.
So it is almost from 80% to 90%. Okay, in early stage non-Hodgkin's lymphoma. So you should go through this MINT trial, and this you should be aware of this. All right. So in MINT trial, they had given 6 cycles of RCHOP. Here you are saying that you want to reduce the number of cycles of RCHOP.
Yes.
And why do you want to do that? Based on what data?
Cycles based on rapid.
So there is a recent flyer study that have given for early stage non-Hodgkin's lymphoma with no B symptoms. They have given just 4 cycles of RCHOP followed by 2R, and that was non-inferior to 6 cycles of RCHOP. So it's a very young patient. You can give 4 cycles of RCHOP. A young patient with early stage disease, no B symptoms, you can give 4 cycles of RCHOP and 2R. Okay. When would you give CNS prophylaxis for patients with high grade non-Hodgkin's lymphoma? So
the patient is having a high like involvement of the bone marrow and other sites like paranasal sinus, paravertebral soft tissue mass, and if there is
basically, I'm asking you, what are the high risk features for CNS relapses?
Yes, sir. So high risk features for CNS relapse includes one is site, sir, which includes paranasal sinus, PNS, paranasal sinus, paravertebral soft tissue mass, any epidural involvement, and age more than 60 years, and bone marrow involvement, and
so you have to remember the most important is testis,
yes,
kidney, adrenal, paravertebral mass, paranasal sinuses. Okay, primary non-Hodgkin's lymphoma involving the breast also have a higher chances of CNS involvement. Okay, there is also another CNS IPI score where if the score is more than 4, then the risk of CNS relapse is high. So if it's a high grade lymphoma, you have to do the CNS IPI scoring, and if it is the score is more than 4, you have to give CNS prophylaxis with either intrathecal methotrexate with or without high dose methotrexate. Okay. Any other questions from any other consultants? Lingraj, ma'am?
No, I'm good, Anant. Nothing from my side.
Lingraj, any questions?
Yeah.
Sumit,
No,
any
sir.
questions?
Sumit has joined. Yeah.
Yeah. So, Akhil, any questions? Mishra sir, any questions? If not, should we move to the next case?
Yes, sir.
Because we've got 2 more cases.
Yeah.
Thank you, sir.
Shravan, you can stop sharing your screen.
Yes, sir.
Mannavi, are you going to share your screen?
Mannavi, put it in the presentation mode, then you can start. Screen is visible.
Yes.
Mannavi, yours is a short case, huh? So you
Yes.
just be brief on the history and then quickly go to the workups and find history and findings. You just brief it quickly.
Yes. So the case is of 65-year-old male patient who was a laborer by
Your
occupation.
slide is not moving, so you can put it in full screen and then.
It's not me.
No, then I think you stop share and no reshare. This is now it is moving.
So
Okay, you go ahead.
65-year-old male laborer resident of Nandur who presented with chief complaints of bilateral cervical and axillary node since 2 weeks. So history of presenting complaint, patient was apparently well when he first noticed swelling in bilateral neck, which was of sudden onset, followed by swelling in bilateral axillary node. Swelling was paleness and was not associated with any symptoms. On examination, there were bilateral level 1B, 2, 3, and 5 nodes. Largest was 1.5 into 1.5 centimeter. Bilateral axillary nodes size, largest 1.5 to 2 centimeter. Nodes were mobile and paleness. On systemic examination, parabdomen was soft and there was hepatosplenomegaly. Spleen was 5 centimeter below left costal margin and liver was 4 centimeter below right costal margin. CVS, respiratory system and CNS all were unremarkable. On general examination, patient was conscious and cooperative. Build was average, weight was 65, height was 165, BSA was 1.7, performance status was 1, and on all general examination finding, only pallor was evident. So coming to the summary, 65-year-old male with no comorbidities presented with swelling of bilateral cervical and axillary nodes of 2 weeks history, and he was asymptomatic for that.
Mannavi, you said the patient has pallor 2+. Is it?
Yes.
So he was not symptomatic for anemia?
No, sir, he was not having any symptoms.
Yeah, so that's odd, So if you're telling that has a significant pallor and the patient is asymptomatic, that's not correlating well. So if you have significant pallor, the hemoglobin is definitely low. Okay.
Yes,
So what did you find in your investigations?
yes. So CBC mein HB was 8.2, total leukocyte count was 80.1, ANC was 6.3, absolute lymphocyte count was 81,000, platelet was 163. In peripheral smear, manual differential count, neutrophil was 7%, lymphocyte was 81%, atypical lymphocytes were 12%, smudge cells were seen. The nutritional parameters of folate was 6.1, B12 was 780, vitamin D was 23.5, iron was 79.7, TIBC was 348.7, coag profile INR was 1.2, PT by UDT was 17.7 by 27.5, LFT liver function test, albumin was 3.4, OTPT was 44 by 13, SAP was 116, LDH was 493. RFT parameters, urea was 37.8, uric acid was 9.7, creat was 1.1, and electrolytes, sodium was 132, potassium was 4.1, calcium was 8.8, phosphate was 5.2, viral markers were not non-reactive, and beta-2 microglobulin was 9.63. So peripheral blood flow was done and smudge cells were seen. Myelite series In myeloid series, polymorphs for 5% and lymphoid series, lymphocytes for 95%. Should I go ahead, sir?
Yeah, you go back first. Go back.
Yes.
Yeah. So here you have a patient who has
Yes.
lymphadenopathy and splenomegaly, right?
Yes, sir.
And you have in your investigations significant anemia with a high WBC count with
Yes.
lymphocytic predominance, and there are atypical lymphocytes seen. And I
Yes.
think these electrolytes and everything you can omit when you present, but just present relevant investigations here. So
Yes, sir. Yes.
this is a case of chronic lymphoproliferative disorder, right? The patient
Yes.
has high lymphocyte count, and so what are the thoughts now, without going for further investigation? What are the possibilities here? And anything here is missing? Anything else you want to do before you proceed to flow? So what are your thoughts in a patient who is 60 years with high WBC count, with lymphocytic predominance and anemia? Okay, so what are the possible differences?
So it could be some low-grade lymphoma.
Okay, so speak in the context of high count in the periphery also.
Because
So can you point out specific lymphomas where you can see this?
so low-grade lymphoma में chronic lymphocytic leukemia.
Okay, that is one. CLL. Anything else?
It could be follicular lymphoma.
Okay, follicular lymphoma. Okay. Anything else?
SLL is unlikely because peripheral blood we have.
Okay. So what are the low-grade lymphomas?
Low-grade lymphomas are small lymphocytic leukemia, chronic lymphocytic leukemia, splenic marginal zone lymphoma, marginal zone lymphoma, hairy cell leukemia.
And finally, mantle cell lymphoma also can present in this way, right? So this patient has high count, splenomegaly, so possibility of chronic lymphocytic leukemia, possibility of mantle cell lymphoma, possibility of marginal zone lymphomas also. So I told what investigation you will do additional, anything you are missing here. This patient has anemia in a background of low-grade lymphoma. Anything else you want to see with an LDH of 490? So what is the role of Coombs test in low-grade lymphomas? When do you do Coombs test?
To rule out autoimmune hemolytic anemia.
To rule out autoimmune. So is it related to the disease or not?
So it's related to disease.
Yeah. Okay. So we'll do a Coombs test to look for any associated autoimmunity leading to hemolysis, right? So what is the significance of beta 2 macroglobulin here?
Prognostic significance is less.
Prognostic significance.
CLL IPA
Yes.
score if it is less than 3.5 and more than 3.5.
Yeah. So beta 2 macroglobulin is a part of CLL IPA prognostic score. Okay. So what was Coombs test done in this patient?
Coombs test was not done.
Okay. Okay. We should have done. Okay. So go to the next slide. Okay. So just read this report. You did have a report of his original report.
Yes,
okay.
Original report.
Okay. So
peripheral blood flow was done, and the reporter was much cells was seen, and myeloid series polymorphs for 5% and lymphoid series lymphocytes for 95%. CD45 was moderate, CD23 200, CD5 was moderate dim, CD19 was moderate, 20 was variable, and 49 was positive. So morphological and immunophenotypic findings were consistent with chronic lymphocytic leukemia.
So how do you interpret a flow report of a chronic any kind of chronic lymphoproliferative disorders? How do you interpret it? So this is given those who are positive, right? So if I give you a flow report of a chronic lymphoproliferative disorder, how will you start interpreting? What are the markers you will
look
see?
at the leukocyte common antigen at the CD45.
Yes, excellent. Okay, so it will be positive in all. So that's why. Next.
Then we look for B cell markers.
Okay.
CD19, 20, 22.
Yes, CD19. Okay. So CD19 is a B cell marker. So it is a B cell lymphoproliferative disorder, right? So now we have, I can narrow down to B cell only. So what are the marker next you will see after you look CD19?
So in this patient or in general?
In general.
In general, then we should also look for T cell markers.
No, CD19 is positive or involved. So the T cell markers are negative. So now we have narrowed down to a B cell chronic lymphoproliferative disorder. So next, what are the markers we are going to see to narrow down your difference? CD10, okay, and
BCL2. That will not be
no.
CD10.
No.
CD10
and
TTD.
So CD10 and CD5. So after you look at CD19, then you go to CD5 and CD10. So depending on the expression of CD5 and CD10, you will again further narrow down your differences. So now how will you narrow down? You have to understand where CD5 is gained and where CD10 is gained in the lymphoma ontogeny. If you have a CD5 is expressed in a naive B cell. No, any B cell which is released from the marrow and which is going to the node. So that is the stage, that is the naive B cell stage where it is not exposed to the germinal center. So that is the place where CD5 comes. And CD10 is a marker of germinal center. Okay. Yes. So now if the patient has CD5 positive, CD10 negative, CD5 negative, CD10 negative, CD5 and CD10 both positive, CD5 negative and CD10 positive. So you have four situations or four scenarios in the flow. Can you just tell me which are the different lymphoma which fall into each categories?
CD5 positive will be CD5 positive will be CLL.
CD5 and CD10. CD5 and CD10 negative. What are the lymphomas which will have CD5 positivity and CD10 negativity?
Mantle cell.
Excellent. Why CD10 negative? Because mantle cell, the cell of origin, is usually a naive B cell, right? So that is the cell of origin. CD10 usually negative. Next, what are the other lymphomas? CLL. Okay. So again, CLL will have CD5 positivity, CD10 negativity. Then you look for 23 and 200 here, right? Which is positive here. So that's why it is CLL. Clear? So yes. The other situation is CD5 and CD10 both positive. What are the lymphomas that are 5 and 10 both positive? Common sense again. CD10 is a germinal center marker. CD5 is a naive B cell marker. So that means the origin is definitely from a germinal center. So what are the lymphomas which will have a germinal center marker? Cell of origin is from germinal center. What are the lymphomas? Tell me some lymphomas where the cell of origin is germinal center.
Follicular.
Yes, excellent. Follicular. Then?
DLBCL.
Excellent. Then? Burkitt. Okay. So these are the three lymphomas which are originated from the germinal center. So they will be CD5 and CD10 both positive. Okay. And the third category is CD5 and CD10 negative. Both are negative. What are the lymphomas? So then we are talking about a post-germinal center group, right?
Yes.
If you remember the lymphoma, the ontogeny, it is now post-germinal center. So what are the lymphomas of 5 and 10? Both negative.
Hairy cell.
Excellent. So we'll have hairy cell, Waldenstrom, that is LPL, marginal zone lymphomas. Okay. Yeah.
Yes.
Okay. So that's how we have to differentiate, categorize first 5 and 10. And now if you have a category that is 5 and 10 both negative, then you'll have the possibility of hairy cell, marginal zone and LPL, and then look for further markers to narrow down the difference. Okay, so now this patient has CD5 positive, CD10 negative, 23 and 200 positive. So this is a CLL. Okay, so now how will you proceed further? What are the investigation you'll do? So here you definitely have to do a Coombs test here. Okay, so if you have not done it, you have to do here to find out the cause of anemia. Whether the anemia is because of a hemolytic hemolysis or it is the anemia related to the disease. Okay? So that has implication in the treatment. Okay. So what are the investigation you will do now from here on? Now you have proven that it is CLL. What is the significance of 49D here? You have done 49D, study 49D. If 49D is positive, what is the significance in CLL? If you know, you just tell.
No
Otherwise,
idea.
you say
No
that.
idea.
So 49D is a prognostic marker. If it is positive, the prognosis is poor. Okay, that's all. So what are the next investigation are going to do?
We look at the
Quickly.
cytogenetics. Cytogenetics.
Okay. Cytogenetics में क्या क्या देखते हैं? What are the cytogenetic abnormality you see in CLL? You ask for a FISH panel.
Yes,
So, but what are the cytogenetic abnormality you are going to see? Can you enumerate? 17P and
13P, 17P, trisomy 12, and 11Q.
And 13Q. Okay. So 13Q abnormality, deletion 11Q, and trisomy 12 and 17P. Okay.
Yes.
Okay. So which are the poor prognostic cytogenetic abnormalities?
17P and 11Q. And trisomy 12 is intermediate.
Yes. Excellent. So any 11Q and 17P is bad. Trisomy 12 is good. Okay. So this patient has trisomy 12. Okay. So next, what is the next step now? Will you do a marrow for this patient?
No, sir.
So will you do a marrow for CLL? Is there any situation we are going to do a marrow for a CLL patient? Or you will never do in any situation? Can anybody answer? Any third year? Okay, so you have situations where you are suspecting an unexplained cytopenias or anemia, like in a situation where you are suspecting a PRC, pure red cell aplasia, which is a autoimmune manifestation of CLL. So there you have to do a marrow to prove it that it is not a hemolytic anemia, it is a pure red cell aplasia. Okay, or unexplained cytopenias, that is the indication where you do a marrow. Okay, anything else you want to do for? So whether this patient needs treatment?
Yes, sir. He's having anemia, so
yeah,
an indication of treatment.
Yeah, so it's an indication of treatment provided it is not a hemolytic anemia. If a patient has hemolytic anemia leading to anemia, then the treatment of choice is only immunosuppression. Okay, they don't need treatment for CLL. If it is a anemia which is related to CLL, then they need a treatment. Anything else you need before you start the treatment for this patient? This patient needs treatment. He is 62 years. Any molecular testing?
IgH mutation.
Yes, IgH mutation status and TP53 mutation. Okay. Yeah. So the patients can have TP53 mutation even if they don't have 17p deletion. So that's why you need a molecular test also to look for any kind of TP53 mutation or IgH mutation. So this patient is IgH unmutated and TP53 negative. What is the treatment they are going to do? What are the treatment options? So this patient is 62 years, trisomy 12, IgH unmutated, TP53 negative, 17p negative, and no evidence of any autoimmune hemolytic anemia. Okay, so what are the treatment options for this patient?
Still, we can give ibrutinib.
Ibrutinib, okay, and
venetoclax.
Venetoclax, okay, only venetoclax.
Venetoclax
single agent.
With rituximab.
Okay, you have to read in that way. So, so the treatment options for this patient is three. One is a chemoimmunotherapy, that is B plus R, ibrutinib, as you rightly said, and third is venetoclax with obinutuzumab. Okay, a CD20 monoclonal antibody, and that is obinutuzumab in frontline. Okay, that is the data with CLL14 trial. Okay, so out of the three options, we have to discuss with the patient, and if it is feasible for ibrutinib in looking at an IgH unmutated status, it is better than giving BR. It has an improvement in progression-free survival. However, there is no difference in overall survival. Okay, based on the ECOG data. Okay, if you give B plus R or any chemoimmunotherapy, it is still fine because overall survival remains the same. So either you use a chemoimmunotherapy or TKI or a novel therapy, the overall survival usually remains the same, unless if the patient has a 17p deletion or a TP53 mutation, where the treatment of choice will be a novel agent, preferably ibrutinib, followed by venetoclax or obinutuzumab. Okay, so these are the three options, and that's how you're going to choose in the clinical practice. Clear?
Yes.
Okay. I think we should. Madam, you want to ask any questions? Madam or Hasmukh sir?
No, no, Lingraj, nothing from my side.
Anant sir? Sorry, proceed.
No, nothing.
Okay, I think Manavi, you can stop. Say, anybody has any question? Residents, you can unmute and ask before we proceed to the last live interpretation. Manavi, you can stop share your screen.
Yes.
Atul, are you going to share your screen?
Good morning, sir. Yes, sir.
Share karo. So Atul, yours is a lab interpretation and we have given a flow cytometry. So don't
Yes,
go
sir.
into the
Yes, sir.
history in detail, just directly go to the report and start interpreting. Okay.
Yes, sir. So, my case was the 50-year-old male. He was presented with the weakness, dyspnea on exertion with the history of 1.5 months and the fever on the off. On the CBC, there were HB 7.9, TLC counts of 69,000 and platelet of 74,000 with the blast of 90%. So even in the bone marrow examination, it was the acute leukemia. So for this patient, I am presenting the flow cytometry. So in the flow cytometry, as you can see, we have to look for the various marker. Either it is the origin of myeloid or lymphoid, and in the lymphoid, the origin of B or T cell. So we can see in the start, the leukocyte common antigen CD45 is positive. Then we can see in the next it is the CD19 and the 34 are also positive with the CD10 positive. In the next fourth number we can see the CD20 is negative and the CD123 is positive. In the next it is also CD25 positive with CD34 positive. It is negative for the or we can say in very small amount CD15 is also positive, and the CD117 and 13 is also positive. CD11 and 36 is negative. CD64 negative, but CD33 is positive, and Cyto 79 is positive and CD3 negative, and the AMP is negative, whereas CD22 is positive.
Okay. So Atul, so when you interpret a report of flow, the first graph, the first graph is a CD45 side scatter, the first left upper one, can you see that side
Yes,
scatter and
sir.
CD45? So that is the first graph, that is called the gating graph, where you gate the cells and you find out which is the abnormal cells. So now in that gating slide graph, where CD45 is y-axis and side scatter is x-axis, you see that
Yes, sir.
red dots, so that is the abnormal cells now. Okay, so these are the abnormal cells. So when you say a report in exam for a flow, you have to first say that this is the CD45 side scatter graph, and these red dots are the abnormal cells or the cells of interest, where we are going to do further analysis to look what is the diagnosis, right? So now when you
Yes,
say
sir.
that positive, negative, it is better to say whether it is bright, whether it is dim, or whether it is variable. So these are the terminologies which are used in flow cytometry report. Okay. So how do you
Yes,
say
sir.
that it is bright, it is dim, or it is variable? Depending on the position of that red dots, that the area of the cell interest in that XY axis. Okay. So now you go to the second one. Okay. So first is
Yes,
45 side scatter. Now the second graph is CD19 in the Y and 34 in the X axis. Now CD34 is a immature cell marker. Is it?
yes,
CD34
sir.
is a immature cell and 19 is a B cell marker, right? So now you
Yes, sir.
see that the red dots are almost towards the right of x-axis and also above that 20% mass. So what do you, when they say positive, they say usually the 20%, any expression beyond 20% is called as a positive. Okay. Now, depending on the position, if it is completely towards the end of the axis, then it is bright. If it is panning out, like if you see CD10, it is almost panning out from the whole axis of x-axis, then it is variable. If it is closer to the 0, then it is and going little bit beyond 20%, then that is called as dim. Okay. So that's how the terminologies are: bright, dim, and variable, and negative. Okay. Or not expressed, you can say. So here it is CD19 is bright, CD34 is bright. So both are expressed. Okay. So as it is CD30 expressed, so it is an immature clone, and 19 is positive, that is a B cell clone. Okay. So that's a B cell immature disease. Now, what are the next thing? So now 10 is bright. Okay. 20 is negative. As you can see that the expression of 20 is absent here, right? All the red dots are almost closer to towards the 0 in the x-axis, right? So this is absent. CD20 expression is absent, and 23 is involved. You see the y-axis is 123, and that is involved, and that is bright positive. Okay. Okay. So now you have CD19, which is bright. What else is there? CD20 is negative or absent, and 22 they have done.
Yes, sir.
Where is 22?
In the last, sir.
Yeah. So 22 is also. I would say 22 is dim. So 19 and 22. So you need two B cell markers to say it is a B-ALL. Okay. You need two B cell markers. Okay. So you have B cell markers like 19, 22, and 79A. Right. So this patient is expressing two B cell markers, the 19 and 22. So it is a B cell lineage. For T cell lineage, you need cyto CD3. Okay. So single only one marker, if it is positive, it is a T cell lineage. Right. So now this is in view of a immature marker expression like 34 with a 19 and 22 expression. So this is fitting into the situation of B-ALL. So now this patient also has expression of 13, right? 13 is
myeloid marker, sir.
Yes, so 13 is a myeloid marker. So what is the significance of that in a ALL, in a B-ALL? So a patient, you are telling it is 19 positive, 22 also is positive. So it's a B-ALL, but it also expresses myeloid markers.
Yes, sir.
So what is the significance?
Sir, in some situation like pH positive, there may be presence of myeloid marker also, sir.
Yeah. So whenever you have a myeloid markers in a B-ALL, you should suspect a pH positive ALL in that situation. Okay. So what are the lineage defining markers for B, T, and myeloid? What are the lineage defining markers?
Yes, sir. So for T cell, sir, it is the cytoplasmic CD3, sir.
Yes.
And sir, for B, if there is CD19 is the lineage marker. If it is strong positive, then we need one extra other B lineage marker, which may be the CD10, 22, or 17-9A.
Yeah.
And if the CD19 is weak, then we out of the other three we required at least two more positive, sir.
Yes. Yes. And for myeloid.
And myeloid, sir, it is the MPO by the sir.
Flow, cytoplasmic MPO. Okay.
Yes, sir.
So as you said, for B you need one bright and one dim, or else two markers if CD19 is absent. For T, you only need one. If you have cytoplasmic CD3, it is lineage defining marker for T. And for myeloid also, if you have cytoplasmic MPO, that is a myeloid defining marker, right? Now, rest all the markers that we discussed, like 13, 33, 56, there are a lot of markers which 117, they can be involved in other diseases also, in B also, in T also. So those situations are called as aberrant expression of markers. Okay.
Yes,
so
sir.
there is one category that is lineage defining markers. The other markers which are expressed across the groups, they are called aberrant expressions. So significance of that has mostly maybe in some cytogenetic subtypes, they can be involved, like in this case where they have CD30 and 33 expression in a BLL can have pH positivity. In some situations, they have prognostic relevance, right? Otherwise, if you have done with the lineage defining markers, then you make a diagnosis of a particular disease. Okay. So that much from the flow. Anyone has any question they can ask?
Madam has asked the relevance of CD25.
So CD25 is present with the cytogenetic abnormality of BCR-ABL positivity.
Yeah, that's correct. So if you have CD25 positivity, that's predict possibility of BALL being pH positive.
Yes.
And what do you think about the CD123 here?
CD123 is not a specific marker. It is present in other means it can present in the myeloid origin leukemia or other, not a specific marker.
But if you have CD123 here, is there any evidence for any specific cytogenetic abnormality or anything?
Sorry, no idea. Hello. Am I audible?
Yes.
Actually, I have not idea
ALL,
of.
as we know, ALL set. No, you are audible. I think it's my. Sorry, am I audible now?
Yes, ma'am.
Yeah, so 123 is more, amongst ALL, 123 is more common in B as compared to T. And again, in BALL, it has association with Philadelphia positive ALL. So very high likelihood that this patient would have pH given the co-expression of other antigen.
Yes, ma'am.
Over from my side, nothing else.
Thank you, ma'am. I think this is the end of it. Anybody has any questions they can ask, otherwise you can close the class. Okay, so thank you all.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.